Good evening. Welcome to the webinar entitled An Update on SARS-CoV-2 COVID-19. First of all, I would like to thank SEIMC and Gilead for the opportunity to hold this meeting, and hopefully it will be of great use to all participants. Without wasting more time, we will start the meeting with the intervention of Dr. Jordi Vila from Hospital Clínic of Barcelona, who will talk about the microbiological diagnosis of SARS. Yeah, okay.
Thank you, Benito. It's for me a great pleasure to participate in this webinar and to discuss with all of you about microbiological diagnosis of COVID-19. My name is Jordi Vila. As Dr. Almirante said, I'm the head of the Department of Clinical Microbiology at the Hospital Clínic of Barcelona in Spain. I'm also currently the president of the Spanish Society of Clinical Microbiology and Infectious Diseases. As you probably know, there are three main approaches to diagnose COVID-19. The first one is the detection of specific genes included in the genome of the viruses and the virus. As you know, this is we are talking about an RNA virus, and we have a PCR and other amplification tools to detect specific genes from the genome. The second approach is the detection of viral antigens. There are several antigens that we will discuss later on that can be used to rapidly detect also the virus in specific samples. And the third is the detection of antibodies against the virus. There are three main antibodies: IgAs, IgMs, and IgG. During my presentation, I want to go through the beginning of the collection of the sample to the end, to the generating a result. The sample that we are collecting, it's a very important step. It's the first step, but it's also very important because a good sample is crucial for a microbiological diagnosis. When we talk about different samples that we can collect to detect the virus, we can talk about oropharyngeal swabs, nasopharyngeal swabs, sputum, and also lower respiratory samples, such as an endotracheal aspirate or bronchoalveolar lavages. It has been shown that nasopharyngeal swab has a more recovery, 63%, related to the 32%, which is the recovery found in oropharyngeal swabs. So this is, as you know, the sputum is not an ideal, well, it's a good sample, but you know, the more of the pneumonia caused by virus, there is no generating sputum. So nasopharyngeal swab probably is the best sample nowadays. As you can see in this figure, this is the way how you can collect the nasopharyngeal swab. Just rotating the swab inside the nasal tract, and then the swab is just inoculated in a liquid media, either of transport or inactivating media. I will discuss this modification, either transport or inactivating buffer. So when we take the sample, we put the swab inside the tube, we close the tube, and we transport the sample to the lab, and we can find two different scenarios. We use an inactivation buffer. So the first scenario is without inactivation of the sample. So we can use a transfer media. Of course, with this transfer media that does not inactivate the virus when the sample arrives to the lab, is required to inactivate the sample, the virus, with a buffer lysis. So this will be the first way to transport the sample to the lab. The second way will be using inactivation buffer, which is a buffer lysis. And if you collect the swab and you put the swab inside tube with 2 mL of buffer lysis, the sample when arrive to the lab is already inactivated on arrival. So you can directly proceed the sample without the inactivation of it, okay? There are also two scenarios concerning where you have collected the sample. You can have collected the sample outside of the hospital, in another center, in another institution, in a health center, different from the hospital. And if you need to transport the sample from this center to the lab in the hospital, you need to be very careful from the biological safety point of view. So you need to transfer the sample on what is called a triple packaging system for biological samples. It's the category B for this kind of sample. So using these samples, you allow a high safety of the people who is transporting the sample, okay? So the second scenario is when we collect the sample inside of the hospital, and then the best way to transport the sample from the emergency department or another ward or the intensive care unit to the clinical microbiology laboratory is using the sealed double bag. That's it. It's enough to transport the sample from these areas in the hospital to the clinical microbiology laboratory. So once the sample arrives to the lab, as I said, we need to open the container, the package, if the sample has come from outside the hospital. Everything is done under the class 2 biological safety cabinet. So you need to check the technician or the people who are performing this work to protect them from a biological point of view. So these people need to wear a personal protector equipment, and this is the way how they are used to open the package and proceed the sample to the next step. The next step for most of the labs that currently have set up a real-time reverse transcription PCR are following 3 steps. The first one is inactivating sample if it has not been inactivated. The second step is the RNA extraction. And regarding the RNA extraction, I would like to mention different approaches. The first one is a specific platform for nucleic acid extraction. Almost all the clinical microbiology labs currently, they have different platforms. You have to adapt this RT-PCR to the platform that you have. And of course, using a specific kit for RNA extraction related normally to the platform that you have for high throughput sample extraction, so a high number of samples. There is a problem here. There are some commercial companies that start to be stock breaking. I mean, if you don't have kits to extract the DNA or the RNA in this sense, you need to use a manual extraction. That is very cumbersome because you need to treat the sample with chrysol and then to extract with chloroform and isopropanol and centrifuge. So it's very cumbersome manual extraction, and it's not recommended, of course, when you have a lot of samples in your lab. Recently has been described a very quick and very effective and sensitive way to extract the DNA or to prepare the sample, which is heating the sample 55 degrees Celsius. Within the virus is disintegrated, is degraded, the RNA is exposed, and then you can go directly to set up the PCR and to perform the PCR without RNA extraction. Of course, the sensitivity of this methodology comparing with the DNA extraction, where RNA extraction is lower. But it's an alternative if you don't have an RNA extraction system to use in your lab. The third step is the gene amplification. There have been several genes that you can amplify. There are several kits, commercialized kits that are used different approaches. And the two most genes amplify are those that you that I mentioned here. The CDC in the United States recommended regions from the N gene. The N gene encodes the nucleocapsid protein, and they recommended 2 different regions from the same gene. The second approach that has been recommended, probably is the European approach, is the detection of 2 genes, the E gene, which encodes the envelope protein, and the RDRP gene, which is a gene encoding the polymerase. So you can use either one, but you need to set up and to standardize these PCRs in your lab. And of course, there are different specificities and sensitivities regarding mainly to the type of primers and prof that has been selected to amplify these genes. So you cannot say that the gene or amplification for a specific gene has a sensitivity of 70% or 80%. It depends of the type of primers and the type of prof that has been designed. There are other amplification systems that probably works also to detect the SARS-CoV-2 virus. One of them is called the reverse transcription loop-mediated isothermal amplification. Is based on isothermal amplification to 60 degrees. It's a very rapid technique. It's 30 minutes. It doesn't need to extract the DNA or the RNA, sorry. You just eating the samples, it's enough to then to perform later on the reverse transcription amplification. As I said, it's 30 minutes. It's not, as far as I know, there is no commercialized any assay based on the loop-mediated thermal amplification, but you can prepare yourself in your lab. There are another systems that are not ready available yet. One of them is the integrated systems. I mean, that means that in the same system you can extract, amplify, and detect the RNA. One of them is a STAT diagnostic from QIAGEN. These include not only the detection of the SARS-CoV-2 virus, but also on other viruses causing respiratory tract infections. Cepheid has launched an express SARS-CoV-2 detection, and bioMérieux also has a tool to rapidly detect the genes, some genes related to the SARS-CoV. It's called RGene. Those are integrated systems. As I said, you just put the sample there, and the same system amplify, extract the RNA, amplify, and detect the amplification product. If we move to the detection of antigen and antibodies, related to the detection of antigens, normally what you can find in the market is a detection of antigens by lateral flow. There are 2 approaches to detect bilateral flow the antigen. One of them is a colorimetric based approach, is the colloidal gold, and the other approach is a fluorimetric approach. For this later one, you need a reader to detect the fluorescence. And the overall sensitivity, at least of the test or size to detection of antigen that we have tested in Spain, the sensitivity is really very low. It's normally below 50%. So it's not recommended to use as a screening for acute infection or the acute phase of the COVID-19. To detect the antibodies, either IgA, IgM, or IgG, we can also use lateral flow, but there are some ELISAs or other antigen antibody assays related to or associated with chemiluminescence that can be used. The problem with the detection of antibodies is that the kinetics of the immune response starts around the 5th or 6th day of the evolution of the symptoms, or the starting of the symptoms. There is not much work done with the detection of IgA. So IgA potentially could appear before IgM and IgG, but needs to be studied and to be know if this can be an indicator of an acute infection. There are also, for the lateral flow colorimetric versus assays, it has been shown the fluorimetric assays are more sensitive than the colorimetric assays. And there is a high variability among the kits related to the sensitivity of the different kits. So my advice is try first before implementing a kit in your lab. Try first and then try to detect by yourself the sensitivity and specificity. So the ones that we have tried in Spain, it has a sensitivity around 60–70%. The sensitivity is about 70% if the patient has more than 10 days of the initiation of the symptomatology. And that's important to take into consideration. So the main application of antibodies detection during the COVID-19 is, first of all, patients who go to the emergency department and are admitted more than 5 days after the onset of the symptoms. Second, in cases with repeatedly negative PCR in which the symptoms have clearly started several days ago, that is to confirm the infection when there is a suspicious of a false negative of the PCR and yet there is a clinical suspicion of COVID-19. Third, detection of antibodies in healthcare personnel that will help identify those who has already immune and can return to the ward to care for infected patients, minimizing the risk of spreading the virus to colleagues and other patients. The other application to detect antibodies is to understand the epidemiology of COVID-19, also allowing us to know the role of asymptomatic infections. And then another one is to define previous exposure and identify high reactive human donors for the generation of hyperimmune serum as a therapeutic approach, which is a therapeutic approach that has been started already. Also detection of antibodies for research work and also for vaccine evaluation. So from my presentation, I would like to give you some take-home messages. First of all, to collect a very good sample is needed for an optimal diagnosis. PCR is still the most often used method to detect SARS-CoV-2. Third, detection of antigens could have been an ideal approach for a rapid diagnosis if the sensitivity would have been much higher than 50 or lower than 50%, which is the sensitivity that we have currently in Spain. Fourth, detection of antibodies could be complementary assay for diagnosis if the sensitivity is over 70% and if the patient has been symptomatic for more than 5 days. And that's all. I would like to show you this picture. This picture, I think it is an allegory of the current situation. This is a human tower from Catalonia. That means that we are nowadays working with realities to combat this huge pandemic of COVID-19 that we have. And that's all. Thank you very much for your attention.
Thank you very much, Dr. Vila, for your clear and excellent presentation. First to go to the question, let me explain you that until now we have around 5,000 of participants in the webinar. Is a good news because the webinar have a lot of interest between the participants. Dr. Vila, we have a couple of questions. The first question is could there be a possible relationship between the amount of virus inhaled during transmission, the incubation period, and the severity of the disease?
Well, I'm sure that there is. I mean, the load of virus or the viral load that you have in the sample has been shown to be related to the severity of the infection. There is a Lancet paper showing some correlation between the viral load and the severity of the patients with COVID. So in this sense, probably the answer is yes, there is a relationship, and probably there's also, of course, a relationship between the viral load that you have in your samples or in your nasal or pharyngeal area, and the potentiality to transmit the virus to another people. and also to contaminate the surfaces, which is also an important way of transmission, just touching surfaces that are being contaminated with virus.
Okay, Dr. Vila, second question. We know that the RNA is usually quite unstable as a molecule. Therefore, does the inactivation of the sample during the transport to the lab in that modality influence the results of the sensibility of the EC by RT-qPCR?
Well, the answer is it depends. I mean, if you're transporting your sample already collected in these buffer lyses in addition of lysing the virus, also stabilize the RNA, the virus. So you can keep the sample for hours at room temperature, and even for weeks, days or weeks at 4 degrees. With these conditions, with these buffer lyses that can, as I said, inactivate and also stabilize the RNA of the virus.
Okay, finally, Dr. Vila, the last question. What's better, to transport the sample directly in a lysis tamper or not? Lysis tampon or not?
We in my lab that we receive around 700 samples a day. We are collecting the samples in a buffer, and so far I think that we have not had any problem, and it's much better than collected, as I said, in a sterile serum fluid. I mean, physiological liquid or another media, because, as I said, the stability of the RNA is much better.
Thank you a lot, Dr. Vila.